Hello and welcome to the lecture on the anatomy of the skeleton. First, I want to start with the different bone shapes. There are 5 of them. First is long. That is going to be bones such as the humerus or the femur. As you can see, it is quite a long bone. You have the carpals, which are going to be an example of short bones, so bones in the wrist. We have flat bones, like the bones that make up the sternum, as well as the bones that make up cranium. Vertebra are irregular bones. This just means that they don't necessarily fit into other shapes, and anatomists decided to name them irregular because that's what they are. And then sesamoid, which is not dissimilar to the term sesame seed, which is where that name gets its derivative from. So what is interesting about sesamoid bones, such as the patella, the bone that makes up your kneecap, is that it grows. You are not born with a sesamoid bone, such as your patella. You develop it later as those areas in those joints, is what that term should say, have a lot of stress and tension. So they are there to relieve that stress and that tension. So very quickly, we are going to recap on bone marrow. Yellow marrow is going to be that fatty marrow that you're going to find in the middle of long bones, and red marrow you're going to find at the ends of long bones, and that serves the purpose of blood cell production. So next we're going to talk about the functional anatomy of a long bone. Specifically, we're going to look at the femur. So this is a nice long bone. This is the bone that makes up your upper leg. It does have a couple of anatomical terms I do want you to know based on its structure. So we do have the epiphysis, which is the ends of long bones. So it can be the head and kind of this like bottom portion. This is where your knee would go. This is where it would fit into the acetabulum of your hip. On these ends, you're going to find articular cartilage kind of covering this end. That is going to ensure that it does not rub bone on bone with the bones that it articulates with. Next, we have the diaphysis, which is going to be the shaft of the bone. And then the metaphysis. The metaphysis is sort of this intermediate area between the epiphysis and the diaphysis. So it's just kind of this middle area. And that will be on both ends. So you have a metaphysis here as well. The diaphysis is that middle shaft area, which also contains a cavity. So it is hollow on the inside. It contains the medullary cavity, which is going to hold your yellow bone marrow. The inside of that medullary cavity is going to be lined with a nice little lining called the endosteum. The outside of the bone is going to have the periosteum. So endo, inside, peri, outside. So moving on to the rest of the bones. We are going to talk about various surface markings on the bones. These are known as bone features. They serve the purpose of relating to various functions having to do with the bones. So elevations and projections are going to be for tendon and ligament attachment. Think about where your muscles need to attach in order for leverage to occur. Depressions, grooves, and tunnels, as well as holes, are going to be where you have blood vessels and nerves penetrating through the bone to get to whatever structures are on the other side of the bone. So you have various holes within your face, and we are going to look at those here next, I believe, which all the places I pointed to are where you have holes which allow for blood vessels and nerves to come through to go to the front of your face. So this is just a list of various bone markings. These various terms fit into, sorry, my cat is being crazy cute at the moment. But you have various terms that are going to mean depressions and openings, as well as potentially ridges and projections. To start with, we are going to look at the axial skeleton. This is going to include the skull, spine, and ribs, so it's that central axis that we are going to look at first. First, we are going to look at the skull. And what I want you to look at first is that the first bone you really notice is what's labeled in yellow, and that is the frontal bone. So that is the bone that makes up your forehead, and it goes from your brow ridge all the way back to this first suture up here. This suture is what kind of connects all of the bones that make up the cranium, and I'm trying to get this to where it's not too bright. So this suture right here is known as the coronal suture. So you can think of that coronal like corona or crown is what it means. So from there, we're going to work our way down. We have the nasal bone, which is this little bone right here, which if you want to, you can touch your nasal bone. So touch a little bit further up between your eyes and gently go down. You can feel kind of a little dip or maybe some type of separation, and that is the difference between your nasal bone and your cartilage. Typically when you break your nose, you're going to break that cartilage. If you break that bone, it'd be really hard to set, but it can be done, I suppose. The bone that's going to make up the majority of the face is going to be the maxilla. So this is going to make up kind of the side of your nose all the way down to your upper jaw. From there, let's go up to the cheek. So that is the zygomatic bone. It's going to compose of this nice little arch right here. From there, I want you to take a peek at your mandible. So that is this entire lower jaw, which it is, if we're gentle, we don't want to break this model, detachable. And that is all just one bone. If we turn our skull to the side, we can see a few other bones, and you might be saying, well, Rachel, you missed a lot of bones and a lot of things on that last slide. Sometimes it's easier to see them from different angles, and that's what we'll be doing. So from the side, of course, we have our frontal bone, which we've already talked about. Separating the frontal bone is that coronal suture from the parietal bone. The parietal bone, you actually have two, so 1 and 2. They are the bones that make up the top of the cranium. The very back of the skull is going to be the occipital bone, and that is separated from the parietal bone by the lambdoid suture. So this suture going across right here. On the side, back to the side here, we have our temporal bone. Temporal bone. You'll notice that there's a hole in the temporal bone right here, and that hole is where your ear canal is going to go into the middle ear. So kind of neat. So imagine an ear being right there. On this bottom portion, we have this rounded bit, and that is the mastoid process. And just slightly anterior to that, we have this more pointed little bit, and that is the styloid process. Whenever you see something that looks kind of weird, either pointed or kind of funky looking, and it's a projection, I want you to immediately think muscle attachment. Typically that's going to be muscle attachment. Just behind the zygomatic bone, we're going to kind of go back right here, and that is the sphenoid bone. Now you can see the sphenoid from quite a few different angles, and we'll see that a few times over. And do know that this actually creates a little bit of a hole. You have this arch right here, and that is known as the zygomatic arch. And the reason you have this little hole right here is because you have a nice big muscle that's going to pass through there, as well as muscles are going to attach to this little arch, and those muscles typically help with chewing. So moving on to the mandible momentarily, we have a few things to discuss with this mandible. One, we have our alveolar arches, which is going to be those little bits that kind of project up into the teeth. You can see them from the front as well. You have the body of the mandible, the ramus, and then you have a few little processes sticking up. So the part that's going to sit into your jaw, like it sits up into the skull, is going to be the mandibular condyle. This little guy, this pointed projection here, is going to be the coronoid process, and again, think muscle attachment. You have a protuberance, so this is just another kind of projection, and that's your chin. So the technical term for your chin is the mental protuberance. From there are 4 holes that I want you to know, but they repeat. So one on either side. You have the mental foramen. How I like to remember that one versus the mandibular foramen, which is on the inside here and here. The difference between them and how you can remember is mental foramen, if you're having kind of like you're thinking, you're having a nice good thought, perhaps you'll hold your chin where you have your mental foramen, and your mandibular foramen are going to be on the inside. So if we remove the mandible, which we already have, and we turn our skull upside down, this is the view that we get. Kind of a weird, kind of creepy view, but hey, it's what it is. The first bone I want to discuss is going to be the maxilla again. So if you look at the roof of the mouth, and if you want to feel it with your tongue, go for it, that is the maxilla, this bone right here. If we move back just a little bit, and you can move back the roof of your mouth with your tongue, you're going to feel the difference between a hard palate and a soft palate. So as soon as you touch with your tongue the roof of your mouth and it goes soft, you have just left the palatine bone and you've entered into the soft tissue that makes up the soft palate of the top of your mouth. Kind of cool. Right in the middle there, in blue on this graphic, you can see the vomer. The vomer can also be viewed looking through the middle of the skull, right here. It's that little separation between the nostrils. So back to the bottom here. You can see that the sphenoid is going to make up quite a bit of the bottom of the skull. So is the temporal bones, and quite a bit of the occipital bone. So the occipital bone is going to be most of this bottom part right here. You'll notice that we have a few holes that we need to mention. This big one, of course, that is going to be your foramen magnum. Magnum meaning large, foramen meaning hole. So it's just a large hole. And as you can probably guess and imagine, this is going to be where your brainstem is going to exit your cranium. And then the start of your spine is going to be here. We do have these little smooth surfaces, and that is where our C1 vertebrae is going to attach and articulate with our skull. I do want you to make a note of the carotid canal and the jugular foramen. Those are where those nice good blood vessels are going to be passing through. And we'll talk about the other foramen of the skull here in just a moment. The bones of the orbit, so the eye socket, you can see that there's quite a few that make up the eye socket. I do want you to know them. But do know that I will not ask you for the palatine bone from this angle. It's a little bit too small, and I'd rather you tell me from this angle here right there, rather than in here. So going around from the top, we do have the frontal bone. We have the zygomatic bone. We have our maxilla. And then on the inside, at the very back, we have the sphenoid. Moving over, we have the ethmoid. And then last but not least, we have the lacrimal bone. And of course, that little piece of the palatine bone. The lacrimal bone is going to contain the nasolacrimal canal, also known as the nasolacrimal fossa. But it is this little canal that is going to connect your eye to your nose, and that's why, well, one of the reasons, why your eye drains into your nose, and when you cry, your nose runs. Most things in your face, if it produces some type of fluid, is going to drain into either your nose or your throat. So this includes your eyes, your nose, and your ears. You do have other little holes or gashes within the eye. The first two being the superior orbital fissure and the inferior orbital fissure. Now, the difference between a fissure and a foramen is that a foramen is usually like a perfect circle. A fissure, I want you to think of as a gash. So it's not necessarily like a nice circle, it's a gash. And then, of course, you have that nice little optic canal there as well. So moving on into the skull, if I remove the skull cap, and we take a peek inside, this is where your brain is going to sit, in case you didn't know. So your brain's going to go right in here, and the brain actually takes a lot of the shape of its container, essentially. So when we move on to the brain, the reason it looks the way it does is because of its container. And it's just kind of cool, So our first bone up here, of course, is the frontal bone. But within the frontal bone, we're going to have this little portion, let me get my finger on it just right, is the ethmoid bone. Within the ethmoid bone, we have two structures I want you to know. That is the cribriform plate and the crista galli. How I like to remember these two terms is that baby Krista is in her crib. So crista galli is going to be the structure in the middle, and the cribriform plate is surrounding it. Now, if you look at this graphic up here, the cribriform plate is porous. It has holes. Those holes are going to allow for nerves to pass through, specifically the olfactory nerves. So it is porous for that reason. If we move down a little further, you can see in pink on this graphic that the next bone is the sphenoid bone, directly in the middle. And if you can see here, that is the sella turcica. Sella turcica translates into Turkish saddle. So it has this nice little kind of ridge to it. It's pretty interesting looking. The next bones that are going to make up the middle here are going to be the temporal bone, a little bit of your parietal bones on the sides, and then of course your occipital bone. And here we're going to talk about some of these foramen within the skull. Let me find my little pin here. So here we're going to have the foramen rotundum, the foramen ovale, and the foramen spinosum, as well as the foramen lacerum, the jugular foramen, and then of course this foramen magnum. Now, a way to kind of remember a few of these, at least these three, as well as this guy, is the order that they go in. So I like to think that we have a cowboy, and his name is Ross. Rotundum, ovale, spinosum, and that is the order that they go in. Ross, our cowboy, is going to sit in his saddle, the Turkish saddle. the sella turcica. And every good cowboy is going to have a lasso, or the foramen lacerum. That might be the dumbest thing you've ever heard in your life, but guaranteed you're probably going to remember that. Do know that just underneath this little ridge right here, we're going to have the optic canal, and then under this ridge, because this is a 2D picture, you can't quite see that it is 3D, that in 3D you would have a hole right here. That's going to be the superior orbital fissure, is where you would see that coming in. And I do like to point out that at least on this left side here, the jugular kind of looks like a J. Like if you kind of squint and tilt your head, it sort of looks like a J. So moving on into sinuses, all I want you to know is that there are 4, and they are named after the bones that they are located in. So you have the sphenoid, the frontal, the ethmoid, and the maxillary sinus. So it may surprise you to find out that there's no such thing as a nasal sinus, because you can't have one in your nasal bone. But you do have these kind of empty spaces, if you will, within your skull. Their reasons are to decrease the weight of the skull. If it was just bone through and through, your skull would be quite heavy. We also humidify air when we breathe in. If you don't humidify the air, it's actually quite abrasive. Chances are you've breathed in during a very cold morning and it makes your chest hurt. We humidify the air typically when we breathe, but when you do get a nice quick breath of very cold air, that can be a little bit alarming to your lungs as well as to your sinuses. They are lined with mucosa. When you have an allergic reaction, potentially during springtime, this mucosa is going to become a little bit inflamed and releasing too much. This is going to cause you to get nice and congested up in here, but you'll notice the next time you have either a cold or maybe you're congested from who knows what, if you push along these areas where you're going to have those sinuses. I find the frontal sinus is my favorite one to push, but you can kind of displace some of the pressure in those sinuses and move some stuff around. It feels pretty good. I do want you to know whether or not teeth are bone. The answer is kind of yes, kind of no, mostly no. The components of bone and teeth are calcium, phosphorus, and minerals. What bones also include that teeth do not is collagen. Collagen, if you remember, is going to be what allows for various structures to heal. So bones can heal, teeth cannot. Once you have damaged or broken a tooth or you get a cavity, that's it. The tooth is kind of, in a way, done. Unless you go get dental work. Teeth cannot heal themselves, bones can. Also, teeth are a little bit stronger than bones, and that's because of the enamel and the dentine. Moving on to vertebrae. There are 24 vertebrae, including the sacrum and the coccyx. So you have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 fused to form 5 sacral, vertebrae to form the sacrum, and 4 coccygeal, which form the coccyx, so your little tailbone. I do want you to know those various curves over there on the left of the screen, so the cervical curve, the thoracic curve, and the lumbar curve. I want you to be able to tell me the difference and which one is which as far as the types of vertebrae. You have cervical vertebrae, which are going to be smaller. They make up your upper neck, so right below your skull, so the first 7. You have your thoracic vertebrae, so there's 12 of those guys, and they're going to kind of be an intermediate size. And they are going to attach to ribs. And they have a costal facet, which means that it's just a little place to articulate with your ribs. And then last but not least, we have our lumbar, which are going to be very big. You can tell from the size of the body of the rib, and the body is just this structure here. The body is much bigger than the other two types of vertebrae. Now, the lumbar vertebrae have to be kind of chunky, a little bit thick, in order to hold up the entire weight of your upper body. So when people say they need lumbar support, that's no joke. You really do need to take care of your lumbar vertebrae. They keep you upright. There are two special vertebrae that I want you to know by name, and that is the C1 and C2 vertebrae. So these are the first two vertebrae at the top of your neck, directly under your skull. It is the atlas, which is C1, which is going to hold up your skull. It is going to allow for you to nod your head, yes, but it technically doesn't move away from the skull at all. You have the axis, or the C2, which has a process called the odontoid process, or the dens, which is going to fit into the vertebral foramen, so that big hole there in the middle of C1. So that little bit is just going to fit right up in there, just like that, and it allows you to turn your head. So it's a little pivot point. So it allows you to shake your head no. So do know the atlas and the axis. I do want you to know the general structure of a vertebrae. So you have the vertebral body, which we already discussed. The vertebral foramen, so that's just that hole. And do know that in this hole, that is going to contain your spinal cord. You do have the spinous process at the very back. So do know that this is posterior and this is anterior. This is an important distinction to make. The spinous process is going to be that little spike that sticks out at the back. And if you feel your back right now, or if you have someone near you who's a willing victim, go ahead and get their permission to touch their back, and you can feel the spinous processes going down their back. The way that the spinous process sits with each other is the one sits over top of the other in a way. So if you were to bend over, the spinous process would become flayed. So they kind of fan out a little bit. In the process of giving someone an epidural, potentially before going into labor or birth, something to that nature, maybe a surgery of some kind where you would need to numb the lower body, you would want the person to lean forward and thus fan that out so that you could get access to the epidural space, which is just before the spinal cord. You don't actually stick an epidural into the cord. That would paralyze someone potentially. So the sacrum is going to be that lower portion of your vertebral column, excuse me. It is 5 sacral vertebrae that fuse together by the age of 26. I'm currently, at this moment, 27, so my sacral vertebrae have probably already finished fusing. The little holes in between are the sacral foramina. I believe that's all I necessarily wanted you to know. And next up we have the coccyx, so that is that little tailbone. What's interesting about the coccyx is that it is 4 small vertebrae that are going to fuse by the age of 30. So as I said, being 27 currently, these have not fused in my tailbone yet. Moving on to our sternum and our ribs. We do have a sternum right here. So first I want to talk about the fact that all of this right here is technically your sternum, and this bone up here at the very top is the manubrium. The manubrium has a special little feature on it, and that's this top portion right here. If you'd like to, kind of touch this point on your neck, kind of your neck and your chest, where you have this sort of spot that sort of pushes in. if you go down a little bit to where you can feel that bone, you can feel it kind of curve like a little smile, if you will. That is your jugular notch. Just inferior to that, we have the body of our sternum, and then our xiphoid process, this little pointed portion here at the bottom. The reason why it's pointed and looks like this, again, if something looks weird, chances are it's muscle attachment. Moving on to our ribs. So what this model is showing is the cartilage. And this is kind of important when we're talking about true versus false ribs. True ribs are going to connect directly with the cartilage to the sternum. Now, once we get past number 7, we enter into false ribs. And what that means is that this cartilage connects to this cartilage and then connects to the manubrium, the sternum, not the manubrium up here. So it connects to the body of the sternum. And you can see that it does that further down here as well. It's just connecting up into the cartilage above it and then to the body of the sternum. Within our false ribs, we have 2 special ones called floating. So that is number 11 and 12. And you can see from this graphic that they're not connected to anything except for the vertebrae. So they're kind of just floating in place. Back in the day when ladies were wanting to fit into their corsets a little bit better, as well as have a nice cinched waist, they would get these ribs removed in order to be able to suck it in a little bit better. Moving on to the appendicular skeleton. So this is going to include your limbs, hips, and shoulders. We are going to start with the clavicle and the scapula. So the scapula, from a front view, this anterior view, is going to be nice and flat, as you can see. This is going to lay against your ribs. So like this flat side is going to lay against your ribs, with this little part sticking laterally, so out. That is what's going to articulate with your humerus. It is known as the glenoid fossa. The posterior view of the scapula is going to have this projection, which is the spine of the scapula. And then we have the acromion. The acromion, this little projection sticking up, is going to articulate with your clavicle. The clavicle is going to sit like this on your body, with this little kind of blunt end touching your manubrium like that. You can actually feel your clavicle right now. So finding your manubrium and kind of working over, you can feel your clavicle, which is your collarbone. And you have 2 of them, one on either side. Moving on to our humerus. Not as funny as it sounds. Sorry, anatomy humor. So you have your humerus here. You have the head of the humerus, and you have the various terms that I may want you to know. It depends on what class you're in. You have the deltoid tuberosity, which is going to be this kind of projection sticking out. And then down here at the bottom, I wish it wasn't so bright. I wish I could balance my light. You're going to have the capitulum or the trochlea, depending on if you're looking more medially or laterally. But the important thing I want to point out is going to be the posterior part of the humerus. And you can see this nice little divot in here. And I'm going to stick my finger in there. So it's this little divot back here. That is called the olecranon fossa. What the purpose of that fossa is for the ulna to sit in there so that you can have this nice joint creating a hinge joint. So as you move your arm like this, the head of the ulna is moving in and out of that little space. Now, if you've ever hit your funny bone, and chances are you have, it's not when you have your arm flat, it's when you have your arm bent and you smack it on something. It's not actually a bone that you're hitting a nerve, the olecranon nerve. And it lives inside of that little fossa. Kind of cool. So moving on to the ulna and the radius. Let me situate them nice and together the way they should be. So you have the part that's going to articulate with the humerus up here of the ulna. And the way I remember the ulna is that the top of it creates a U. The radius, as the name implies, is going to radiate around the ulna. So if you take your arm, making sure I don't run over a cat, if you take your arm, put it out flat, you can turn your palm like this. And what you'll notice is that your radius, which is always on the side closest to your thumb, so this bone right along here, is going to radiate over, so it's kind of tilting over to the other side as you do that. Radiates over. You'll also notice at the bottom of these two bones, we have two more styloid processes. So just those little points. The next bones we have are going to be the bones of the hand. Probably some of my favorite bones just because they're quite interesting and very, very different. So first and foremost, we need to know which part of the hand we're looking at. We are looking at the right hand, and we know that because the radius is going to be right there, and this should be the palm facing up. So from here, and I wish I could kind of show you a little bit easier, again with this lighting, we have the carpals, which are going to be the bones that make up the wrist, where my pinky is down here, and they go in this special order. They go scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. And that's going from right to left, bottom row to top row. And the way that I like to remember these is a saying that I heard back when I was taking anatomy, and that is, some lovers try positions that they cannot handle. And you will remember this for all eternity, I'm sure. But that is my favorite little saying there, to remember the order of your carpals. So some, scaphoid, lovers, lunate, triquetral, positions, pisiform, that, trapezium, they, trapezoid, can't or cannot, capitate, handle, hamate. And that should hopefully help you remember the order of your carpals, your wrist bones. Next up, we're going to have our metacarpals. This is what makes up your palm. So these longer bones right here. These are the metacarpals. They are going to be labeled 1, 2, 3, 4, and 5. Your thumb starts off number 1 and ends with your pinky at number 5. From there, moving up, we have our phalanges. The phalanges are going to be just past the metacarpals. The phalanges are going to be labeled as such: proximal, middle, distal. And you'll notice I left out the thumb. The reason I did that is because the thumb only has 2 phalanges. It has a proximal and a distal. The rest of your phalanges have 3. The toes are also going to follow this order. Your big toe being number 1, your baby toe being number 5, and your big toe only has 2 phalanges. There is no middle phalange in your big toe or your thumb. So if I were to ask you on an exam, what is this bone right here? You would tell me it is the third middle phalange. Let's try another one. How about in blue? This one. It is the first distal phalange. And that is the proper name of these bones. Now, if I just ask you, what is this one? And you tell me it's a phalange, that is wrong. It is the fifth metacarpal. Okay. So moving on to the pelvis. I don't actually have a sacrum with me or an articulated pelvis, but I do have these two halves right here. And they actually sit like this. Ooh, guess you can't really see. Like this. So with these two bones kind of coming together, these bones pointing down, and then these big flared parts are going to sit up. Now the other important thing to make a note of is that these kind of pockets right there are going to stick out laterally because that's where your femur is going to fit in. There's a few things that I want you to know about the pelvis, but let's go over a few things that might be a little bit less, obvious. I actually like this next picture a little bit better to show that. It just color coordinates a little bit nicer. So in purple, you're going to have the ilium along with the iliac crest. And if you need to go back to that last picture, be my guest. There might be a few things that I accidentally leave out here. In yellow, you're going to have, I can't see that for the life of me, the ischium. And if you want to think of this one as being a bony butt, that is what it is. So if someone has ever sat on your lap and they kind of push down a little hard, or maybe they sit on you in just the right way and they've got that little bony projection on their tush, that is that bone. And then here we have the pubic bone. And in the middle of the pubic bone, we have this little bit of cartilage here, which is going to be the pubic symphysis. And then last but not least, make sure you know that this little kind of cup-like structure is going to be the acetabulum. And that is where the femur, the head of the femur, is going to fit into. I do want you to know a little bit about the difference between male and female pelvises. It's a way to determine someone who is deceased if you only find bones, or possibly you're an anthropology major or an anthropologist of some kind. You may look at the pelvises to determine whether or not an individual was male or female, as well as if it's a female, if they've given birth. So one of the biggest things that I think is most noticeable is this angle of the pubic angle. So it's either going to be 100 degrees or more on a female, so wider, or it's going to be more narrow, so 90 degrees or less for a male. You can also tell from the pelvic inlet, it's wider in females than it is in males. So that is obviously for reproductive purposes, allowing for a baby to pass through. So moving on to the femur, So you do have the head of the femur, and then if I can get you to see this, there's a little divot right here at the head of the femur called the fovea capitis. You have the neck of the femur. You have the lesser trochanter. And then here on the back, not shown very, very well on this model, but we'll make do, you have the gluteal tuberosity and the linea aspera going down here. This is the patellar surface. It's a little bit smoother. If we look at the posterior of our femur here, you can see that big divot. That is the intercondylar fossa. And just to make a point, I can stick my finger through there. So that's how you know that is the back of the femur. And then you have your medial condyle. So medial meaning middle. And then lateral epicondyle, or lateral condyle over on this side, meaning the outside. That moves us on to the tibia and fibula. So don't get them too mixed up. So don't call it a tibula and a fibia. Those are not correct. It is tibia and fibula. If you want to think of it this way, fib has an L like lies. So fib, fibula, lies, L. Again, dumb ways to remember things, but hopefully you never forget it. So the tibia is this bigger guy right here, and it has a special little surface, or not surface, I'm sorry, it has a special little structure on it, and that's this thing right here. If you take a look at the inner part of your ankle, you're going to see this little projection. I wish I could, yoga my foot up into the camera. But if you look at the inside of your ankle and you see that kind of rounded projection there, that is this. It's what you hit on everything if you hit a table with your ankle or something. You also have a lateral malleolus, but that is going to be on the fibula. And there may be a few other structures. The interosseous membrane is going to be a membrane that is going to connect the two. You also have an interosseous membrane that is going to connect your radius and your ulna. So you'll notice that the upper limbs and the lower limbs are very, very similar in their structure on humans. So our humerus and our femur are pretty similar. Obviously not exactly the same in shape or size, but they're very related. They're very similar to each other. Likewise, our lower leg, including the tibia and the fibula, as well as the radius and the ulna, they're very similar as well. So two bones making up the forearm and the lower leg. Moving into the last topic, we do have our foot. So you do have your tarsals. So much like your carpals, your tarsals are the bones that make up your ankle. There's all these bones right here. This big bone back here on the bottom, that is the calcaneus. That is your heel. On the top, you have the talus. The talus is the only bone of your tarsals that articulates with your lower leg bones. So your tibia, more specifically, a little bit of the fibula, mostly tibia. But the talus is the one that articulates with them. Moving forward, you have the navicular, and then you have the cuneiforms, and you can call them first, second, and third, or if you want to be more anatomically correct, you can call them medial, intermediate, and lateral. Next to those, you have the cuboid, and those are your tarsal bones. They're a little bit easier to remember than your carpals. Just don't confuse carpal and tarsal. You will be wrong if you tell me one versus the other. Next, we have the metatarsals. Not dissimilar to how the hand is, the metatarsals are these longer bones that are going to make up kind of the middle part of your foot, and if you touch your foot right now, you can probably feel them. From there, we have our phalanges. Obviously, the phalanges on our toes are a lot smaller than the phalanges on our fingers, but they do the exact same sort of pattern here. So, if I were to ask you, what is this bone right here? You would say that is the fourth distal phalange. Let's try another one. This guy right here. That is the first proximal phalange. And if you want to indicate whether or not we're looking at toes versus fingers, you can say pedal or manual versus, each other if you really wanted to, but I'm not going to ask you to go into that much detail. So that just about covers all the bones.